Good afternoon, ladies and gentlemen. And this is one of the most important session that we can think about in this. Actually, it's a partly respiratory, partly cardiology, but ultimately, whoever the people treating the patient, it should be a combined effort to get the maximum for the patient. For this regard, we have a good lecture on evaluation and management of pulmonary hypertension in chronic lung disease. It's my honor and pleasure to invite Dr. Laura Price from UK. She is consultant respiratory physician and pulmonary hypertension physician from Royal Brompton Hospital, and she is honorary senior lecturer to the Imperial College, Associate Evaluation and Management of Pulmonary Hypertension in Chronic Lung Disease. Over to you, Dr. Laura.
Thank you. Well, thank you for the really marvelous invitation to be here. I'm delighted to be here. So thank you all. We have 25 minutes and I've got quite a lot to say, so I will begin. I have some disclosures and the overview I'm going to talk about. This is group 3, so lung disease related pulmonary hypertension, of course, not touching on all the other important types, but maybe another year. So really, I'm talking about the classification of all kinds and thinking about what happens in pulmonary hypertension due to chronic lung disease, approaches to the diagnosis, and options, therapeutic options. So this is an important concept that we divide pulmonary hypertension into 5 groups. And this is broadly based on the observation in group 1 that in the 60s, many people with different diseases looked the same when their lungs were examined under the microscope. So this is the pulmonary arterial hypertension, and it's divided into subgroups, predominantly rheumatic conditions such as scleroderma, congenital heart disease. And then when we've excluded all the other kinds, including HIV, liver disease, there's idiopathic, which is driven by unknown multiple factors. The important thing is these are grouped together in the clinical trials. There's evidence for treating these. The remodeling, as you can see in that diagram, is severe in the pulmonary arteries, all the layers of the vessel wall. And these patients die of right heart failure. And we really, they're not very common. It used to be called primary pulmonary hypertension, but the group 1 is not to be missed. That's not what I'm going to talk about today. And just to mention that group 4, that due to chronic thromboembolic disease, also very important to treat those, identify those patients, because they, in the UK and other centres at least, there's a specific pathway leading to pulmonary endarterectomy. So those 2, if you're looking at all kinds of pulmonary hypertension, are probably the most important. You won't see them very often, but certainly pathways should be existing to try to identify those patients. What I'm going to talk today about, however, is that in group 3, so pulmonary hypertension due to lung diseases and or hypoxia. So if you think about the different lung diseases within group 3, listed on the slide, so COPD, ILD, sleep disorders, you also may see group 3 patients with CTD, interstitial lung disease, and also patients who have sarcoid, who develop lung abnormalities, fibrosis. Listening to the talks last night, obviously, post-TB fibrosis should be fitting into that too. So how do we define pulmonary hypertension? It remains a hemodynamic definition, ideally made at invasive assessment by right heart catheterization in countries where this is available, obviously. And we have redefined this according to more available data on the normal ranges. So it used to be a mean pulmonary artery pressure above 25. That's now come down to 20. And also the use of the wedge pressure is really important. I'm sure you've had talks on this before, but just to remind us, the left atrial hypertension, the elevated pressures on the left side of the heart can be estimated using the pulmonary artery wedge pressure. And that divides into group 2, so left heart-driven pulmonary hypertension and everyone else, so all the others, 1, 3, 4, and 5. And why that's important, and you may suspect pulmonary hypertension due to left heart disease with clinical risk factors such as obesity, hypertension, atrial fibrillation, someone's likely to have some left heart disease. Or you may see a large left atrium on the echo, simply. But to confirm this, you may, in some centres, want to do a right heart catheter to measure that wedge pressure, sometimes also elevating the fluid resistance by giving some fluid challenge, and you'd have a stiff left heart and you'd elevate your left pressures on the pulmonary wedge pressure. And the reason that's important is that you don't want to give those patients pulmonary vasodilators because you can precipitate pulmonary edema. You may suspect it, but to confirm this, ideally, many times you need to do a catheter test. So in the UK, what do we see? So this is our way of working. I realised how lucky we are. We have a very networked group of physicians in 7 adult centres, all just doing pulmonary hypertension. We see mainly group 1, about 44% of what we see. If I point this here, it doesn't work brilliantly. So group 1 is mainly what we see. Group 4 is about 25% of what we see. And lung disease-related PH is about 5-7% of what we see nationally. And within ILD, you may say how common. And we look at this differently in ILD and COPD because we realize they're behaving quite differently. The pulmonary hypertension behaves quite differently. Most of the patients assessed by echo or cath and varying prevalence depending on the disease stage. For example, in IPF, when you first see a patient in clinic, you may have an 8 or so % prevalence of pulmonary hypertension, whereas much higher prevalence when you're assessing patients for transplantation. Similarly with the other conditions, sarcoid included. So the prevalence depends on when you assess your patient during their disease course and how you do it. We do know, of course, the impact of group 3 pulmonary hypertension is adverse. Symptoms, quality of life, and mortality are all impacted. For example, in our cohort of patients at Brompton who have developed right heart cath confirmed pulmonary hypertension due to their ILD, 1-year survival is only about 50%. Dropping horrendously. And that's really highlighted in the graph on the left. The dark blue line is all lung disease-related pulmonary hypertension. This is data from the national audit in the UK. So all pulmonary hypertension drives an increased mortality, but of all the subgroups, lung pH is the worst. And if you divide lung pH into the 3, so sleep and hyperventilation, pH due to COPD in the middle curve, and pH due to ILD on the bottom curve, ILD pH is the worst out of the lot. So why might that be? And that's just to reflect back on survival curves for a moment. This is a 1998 publication of IPF all-comers compared to non-IPF. So the NSIP, I'm sure you remember this curve. If you have a patient who's got NSIP or UIP, your survival is hugely different. That's in all comers. However, if you look at the same curves in patients who have pulmonary hypertension, due to those 2 groups, there's no difference in the curves, suggesting that once you have pulmonary hypertension, that's what drives the outcome. And why might that be? It appears that the right heart function is even worse in patients with group 3 than group 1 pulmonary hypertension. Here shown by the fractional area change, which is an early sign of right heart radial dysfunction picked up on echo that is very, very early in the sort of course of the right ventricular function declining. Even for a degree of high pressure, that right heart function is worse on the right graph in patients with group 3 versus group 1, and that's probably driving the outcome. Looking at the distribution, I think is interesting, especially in the population here with non-smoking COPD. If you look at the spread, now this is right heart catheter data, but echo would probably do, you have many patients with COPD who have mild pulmonary hypertension. So it's a left skew of the distribution of the pulmonary hypertension. So very few have a mean peer pressure above 35 or 40, so a severe end of the spectrum. So COPD, mostly mild pulmonary hypertension, very few, but important few, have severe pulmonary hypertension. And we really want to find those patients, and more of that later. Whereas on the right curve, bell-shaped distribution, many more patients with ILD have more severe, more a sort of normal distribution of the pulmonary pressure. So larger numbers of patients with severe pulmonary hypertension. We do know this is unfortunately a progressive observation. Patients with pulmonary hypertension, it doesn't go away. It does get worse as you monitor this. We also know that any degree of pulmonary hypertension impacts on survival. So you can see the curve. The top line is no pulmonary hypertension. And the bottom three are sort of medium levels, moderate levels, and severe levels of pulmonary hypertension. The impact on mortality, it remains there, even if you've got mild, because it's a progressive disease. I think this is quite important to think about why. So first of all, we know the impact of acute hypoxia. Anyone challenged by acute hypoxia, your pulmonary hypertension happens, your pulmonary pressures increase by up to 30%. And this is our normal acute hypoxic vasoconstriction in all of us. And the clinical correlates of this are important to remember in terms of when we assess patients, because you don't want to assess somebody with pulmonary hypertension in a week after they had an acute exacerbation, for example. And I like reflecting on this 1969 study of subjects with acute exacerbations of COPD who agreed to undergo a right heart catheterization before, during, and after their acute exacerbation. And it reflects on the left is the PO2 improving, and on the right graph, the PA pressure normalizing, just reminding us the importance of acute hypoxic vasoconstriction and what we do about that. We don't, if you see a right ventricular pressure that's really high in the middle of an exacerbation, you're not going to do anything apart from support that patient's exacerbation. You're not going to jump in with pulmonary vasodilators, for example. What's important, of course, is the impact of chronic hypoxia. We know that even 6 weeks of simulated high altitude leads to structural changes, so chronic hypoxic vasoconstriction and remodeling. So really just to say about this is that this is prevalent in all conditions where you have lung hypoxia. And it's a normal, probably a protective mechanism to protect the distal capillary bed when faced with chronic hypoxia. So we're going to see this all the time. It usually leads to mild levels of pulmonary hypertension, and the treatment sometimes is oxygen. But it's more than just this happening. Some patients get very, very severe pulmonary vascular lesions. And at the moment, given the evidence base, they're the patients we're trying to find. This is shown by many ways, but for example, histological evidence in a COPD study shows where you can have concentric laminar fibrosis, all layers of the vessel wall. Sorry, this is the one. Mild degrees of remodeling, moderate degrees, and severe degrees of remodeling in a patient group with COPD. And the level of intimal and vascular proliferation of the smooth muscle layer correlates with the extent of the hemodynamic impairment. So that's one thing. The other thing that's complicated in lung pulmonary hypertension is that the lung is incredibly heterogeneous in the way the vascular bed reacts. And you can have all layers of the pulmonary vascular bed affected. For example, what we've just seen in that other slide, the smooth muscle layer is hypertrophied. In the middle layer, you've got a very intense lymphocytic infiltrate, reminding us the importance of inflammation in this phenotype. But also there's venous involvement. So in IPF, for example, it's not just the remodeled pulmonary arteries, but there's abnormalities in the pulmonary veins. And if that reminds us of the rare pulmonary veno-occlusive disease phenotype, where these patients are incredibly difficult to treat, because that, like left heart disease, if you give them pulmonary vasodilators, you can precipitate pulmonary edema. There's the increase in blood flow. There's nowhere for it to go. So just bear in mind the complexity of the lung, even within an individual patient. So why do some patients get exaggerated to group 3? So there's an exaggerated phenotype of pulmonary vascular remodeling. We think it's probably a second hit after the mild levels of hypoxia. There's certainly evidence for endothelial cell dysfunction, smoke of all kinds, genetics, oxidative stress, inflammation. And of course, there may be underlying drivers for a pulmonary vasculopathy, such as a sarcoid or a connective tissue disease itself. Secondly, the mechanical effects of lung disease, the impact of coexistent emphysema, for example, in patients with IPF is very important. It's like a double hit. And you can imagine the vascular destruction in those patients. Similarly, patients with sarcoid, post-TB even. So the mechanical impact of the structure of the lung destroying the vessels with it. And these big three comorbidities, in a very practical sense, if you have faced with a patient you think has pulmonary hypertension who's got chronic lung disease, these are the things to exclude. Have they got acute on chronic or chronic thromboembolic disease, so CTEPH, and it's a case for a CTPA? Have they got untreated hypoxia or indeed sleep disordered breathing? And this very prevalent complication of diastolic LV dysfunction or HFpEF can really drive up the BNP if you have BNP, risk factors, as I mentioned earlier. But these comorbidities are important to detect and treat as a primary thing. So how do we find these patients? How do we detect the onset of pulmonary hypertension in patients with lung disease? And these are your symptoms and signs of patients with PH. And it may be very non-specific. The onset of out of proportion desaturations, out of proportion breathlessness, onset of right heart failure symptoms would be late, but of course that would be raised JVP, hepatomegaly, and of course leg swelling. Patients with lung disease who develop pre-syncope or syncope on effort is really important and certainly a red flag. And that's a specific cause of syncope due to pulmonary hypertension. So those are useful, mostly, maybe, but can be non-specific, as I said. ECG changes, you may see these. In the group 1 literature, if we see ECG changes such as sinus tachy, P pulmonale, and then right heart strain morphology, they tend to indicate more severe pulmonary hypertension and can actually improve as your right heart function improves. So if you see those, definitely suspect pulmonary hypertension. But just to highlight that if, for example, in these slides, which are in patient population with ILD, it's not clearly driven by the severity of the underlying lung disease. And this is what I was trying to pick up on before. So FVC and mean PO pressure, there's no clear correlation, either using lung function or a CT score of the extent of fibrosis. So obviously it's important that the lung disease is progressing, and we look at serial change, it's extremely important. But there's some patients where the pulmonary hypertension is even more than you'd expect, meaning there's other mechanisms. So gas transfer and serial gas transfer assessment is really, really important. So you'll be in your respiratory clinic with ILD or sarcoid patients. If you see an isolated fall in the KCO and the TLCO, that suggests there's a pulmonary vascular phenotype. And if you see over time these falling, it suggests the presence of pulmonary hypertension or indeed CTEPH, and you should ideally look for it. We've looked at our data over 3 years, and just to highlight the bottom two, in the last year, especially on the TLCO, the KCO, whereas the FVC remains static in long-term follow-up in ILD patients, fibrotic ILD, the gas transfer tends to drift down before a diagnosis of pulmonary hypertension in these patients, in the sort of year or so before. So you can predict, if you're starting to see this, the patient may be developing pulmonary vascular disease. Simple things too. So CT chest, non-contrast even, are very, very instrumental in detecting the enlargement of the pulmonary artery adjacent to the aorta where the pulmonary artery splits, where it bifurcates. So those should be a ratio of 1:1. If your pulmonary artery is bigger than the adjacent aorta in all kinds of pulmonary hypertension, it should trigger you to think, has this patient got PH? It's a very useful sign. And we published on this in chest. The right heart dimensions are also available for you on the CT chest. To be fair, it's hard to see the right heart chamber dimensions with a non-contrast CT, but you can see the right ventricle lies anteriorly, and it shouldn't be bigger than the left. It should be a crescent around the left. So you can see signs of pulmonary hypertension on simple tests, notably CT scanning. So screening protocols are coming through. The whole ethos of this is because there's treatments available in some countries at least. So how can we detect these patients? We know that as I said, in the COPD population, there's a certain number who have severe pulmonary hypertension, and we want to find them. There's a study where they've combined the systolic PA pressure on echo, so different to the mean at cath, the systolic estimates from the TR velocity, combined with a high BNP biomarker, and with the PA bigger than the aortic ratio on the CT scan. And those gave great negative and positive predictive values of severe COPD PH. So that's very useful. Similarly, in ILD, we did a score simply using echo to predict severe pulmonary hypertension in ILD. So these are coming, depending on what you have available, as to pick out the patients who might be amenable to treatments. So ESC guidelines for this, we're still sitting on the fence in terms of who should be assessed, really, but there's more and more studies coming out. What I will just do for my last 5 minutes is talk about what we do in the UK and think about what you could think about doing here. In 2008, all we were able to do is treat the primary lung condition, oxygen, 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 and think about pulmonary vasodilators when there's more pulmonary hypertension than you would expect for the degree of lung disease. I want to highlight the importance of pulmonary hypertension treatment purely by maximizing the lung disease treatment, for example, in a patient population with obesity hyperventilation. 3 months of effective non-invasive ventilation improves the BNP, the mean pressure, and the PVR. So you don't need complicated medicines. You need to remember this. It's incredibly important. So in this population, you don't need pulmonary hypertension treatments. But what we do have in group 1 and group 4 pulmonary hypertension is loads of pulmonary vasodilators working in amazing ways. So what about these drugs in group 3 pulmonary hypertension? And it's obviously a big thought in our centre, where we have a lot of patients referred from the ILD team. I believe Athol Wells was here last year. So we see these patients a lot. This is a very well-known slide in pulmonary vascular biology. So this is your remodeled pulmonary artery, and there's the 3 pathways to modify. So on the left, the endothelin pathway. Endothelin is evil. It causes proliferation and anti-apoptosis of all the layers of the vessel wall. We want to block it with drugs that end in TAN, so bosentan, ambrisentan, macitentan, orally available, not otherwise, not IV. The middle pathway, nitric oxide pathway, and the right side pathway, prostacyclin pathway, are underactive in all kinds of pulmonary hypertension. We can augment nitric oxide signaling with PDE5 inhibitors that break down CGMP, and the prostacyclin pathway, we can give synthetic prostanoids. Talk more about that later. In my last, is that 3 minutes until 25? Okay, so we better be, basically, not many treatments are available. Sildenafil, there's some data, it's safe. The STEP IPF study of all comers with the likely pulmonary hypertension selected with a DLCO of under 35%. They didn't meet the primary endpoint of 6-minute walk, but there were some other secondary important endpoints. But what was interesting is in 120 patients who had echo, those who had right heart dysfunction did improve their 6-minute walk, suggesting that if you phenotype the patients, find the right patients, you'll have a positive study. Now, we don't have a positive prospective multi-center study of sildenafil because no one's paid for it. But what we have done is looked at our 20 years of data in the Brompton and showed that there was a significant increase in survival of over a year with sildenafil. And that was true across all the types of ILD, so chronic HP, IPF, and so on. We know that patients, when you treat them when their right heart is still normal in function, they survive even better. And the big news is this new treatment in a very important multi-center study, not available here, but it's coming in the UK, not yet at least, of the inhaled treprostinil. This showed an amazing, almost unbelievable walk distance improvement at 16 weeks in 31 meters in patients with right heart catheter confirmed pulmonary hypertension. Not so effective in patients with combined pulmonary emphysema fibrosis syndrome, which I imagine is common here. Very difficult patient group, apical emphysema, basal IPF pattern, very, very difficult. Oxygen, palliative care, diuretics. And those patients who with COPD were studied recently, this has just been published, there was no benefit in COPD PH with this amazing new drug. So it really is for ILD PH. Just a moment to say that sildenafil, which we have here, probably also improves survival in COPD PH in the both severe and non-severe patients. So really to conclude, patients who have pulmonary hypertension with pulmonary hypertension with either ILD or COPD, there's enough evidence, I think, to propose sildenafil. The caveat being it's not been subjected to a prospective multi-center study, but there is a lot of real-world data, and we know it's safe. The ideal treatment is in this graph sketch by, I was part of a group, it's in Lancet Respiratory Medicine, thinking about the ideal approach. You would cath your patient, you'd look at the severity by PVR threshold, you would avoid endothelin receptor antagonists in ILD-PH. We didn't talk about that, but based on other studies. But you would try to treat patients you can with severe levels of pulmonary hypertension with sildenafil, and ideally ILD-PH with inhaled treprostinil if you have access to it. Now, this is my last slide. This is what we do in the NHS. So we think about, optimizing the underlying lung disease, and I highlighted that with the obesity hyperventilation slide. Oxygen, according to COPD guidelines, pulmonary rehab and use of diuretics, we often use a combined loop, sometimes starting with furosemide, later bumetanide with spironolactone, often eplerenone in men. If you have eplerenone, it causes less nipple discomfort. The practical things we do. Find those important comorbidities. Don't miss CTEPH if you can access a CTPA. Diastolic dysfunction, super common. HFpEF, think about your risk factors for that. So AF, obesity, diabetes. Wait 2 seconds. Sleep disorders, treat them first. And of course, the exacerbations increase your PA pressure, as we know from hypoxia, acute hypoxic vasoconstriction. Now, in the UK, we refer patients for lung transplantation. We do treat because we have pulmonary hypertension therapies, especially patients with sarcoid, CTEPH, connective tissue disease. And really, what to think about here. I'm happy to take some questions, but thank you for listening.
Thank you. Thank you very much, Dr. Laura Price, for your wonderful presentation on very critical site in our pulmonology subject, that is the evaluation and management of pulmonary hypertension in association with chronic lung disease. Sometimes it is very difficult to find out the pulmonary hypertension, but we should keep in our mind in management of chronic lung disease whether there is associated pulmonary hypertension present or not. And after that, we need proper evaluation and giving treatment accordingly. We have many options to treat pulmonary hypertension nowadays, but in some chronic lung disease, we are facing some difficulties yet. So more and more research and work is needed. So thank you again. Now is the time for question answer session. If there is question, please come forward on the microphone, before the microphone, and ask any question regarding this. Thank
you. Regarding connective tissue disorders and related pulmonary hypertension, when the patient also has interstitial lung disease, when the patient has connective tissue disorders like scleroderma, when the patient also has interstitial lung disease, and how do we know that? You mentioned clearly that if the degree of the interstitial lung disease is very minimal, then we can assume that if it is disproportionate, then it is very likely there is a component of grade type 1 pulmonary hypertension. But when there is a significant degree of interstitial lung disease, and how do we know whether the type 1 or type 3 contribute to the pulmonary hypertension?
Yeah, it's a really important question. It's one of the most difficult ones we debate in our MDT. Obviously, maximizing of the lung fibrosis treatment is essential. Oxygen is needed. But if they've got scleroderma, they have different phenotypes. You do all make sure they've got no other cardiac phenotype or inflammatory cardiomyopathy. If they've got proper pulmonary hypertension, those patients should be treated if they've got not extensive ILD as a CTD-PAH patient with combination therapy with a PD5 such as sildenafil, and we have bosentan here, and then reassess. We sometimes do treat patients with prostacyclins in that group, but yeah, it's the two compartments that behave together, and they can be very difficult to treat, and they don't do very well.
So one more question. Which degree of pulmonary hypertension could be considered a contraindication for lung transplantation?
So we have that very much in our pathway. So as I said, the group 1 patients with the scleroderma patients, as long as they don't have significant reflux, that's an absolute contraindication. But if they're otherwise not too many comorbidities, we would refer once they're on maximum treatment and worsening at that point.
Irrespective of the degree of pulmonary hypertension, is it irrespective of the degree of pulmonary hypertension, whether if a patient with a chronic lung disease have a severe pulmonary hypertension, would it contraindicate lung transplantation?
So there's transplant criteria for group 1 pulmonary hypertension with a cardiac index under 2. If they've got lung fibrosis as well, it depends on the patient. But they're generally considered as a group 1 patient with the transplant criteria. Yeah.
Thank you.
Thank you.
So, patients with COPD and severe pulmonary hypertension.
Sorry.
I mean, these patients can be extremely sick. So you said that there's real world data for sildenafil in these patients.
So it's only based on an observation from this large study of real world data, 850 patients, where they saw a survival benefit. This is not prospective data, but it's showing you something, glimmer of hope. Similar data shown in a severe PH COPD cohort, but no studies have really shown a great benefit in COPD. And importantly, the perfect study just published by Steve Nathan, inhaled treprostinil, even in right heart catheterization confirmed severe PH in COPD, it didn't have a benefit and in fact had worse adverse events. And the problem with airways disease is the risk of VQ mismatching.
Right.
But there's something about sildenafil that seems to be tolerated well, and you can always stop it.
So would it be advisable to do a treatment trial? Maybe if a patient has evidence on echocardiogram?
I think in this arena where you are, you do the simple things you can do first. You have to make sure you're diuresing properly, oxygen, NIV as needed. Exclude any connective tissue disease. And if they're euvolemic and you don't have clear left heart features, either clinical risk factors or on your echo, so, what you can do with what you've got is looking at the left atrial size and some indicators of left heart. That would be a really interesting talk just to show you how much you can get from an echo. I think it's reasonable. These patients haven't got other options, have they? If you've got severe pulmonary hypertension in COPD, based on this study, which is from the Go Deep registry, and the first author is Werner Sieger from Gießen, from Germany. So read it and see they would be reflecting on that. I think you have to make do with what you've got at the moment. Be aware of the risk of pulmonary vasodilators when you haven't be sure that you've excluded left heart disease. And you can precipitate pulmonary edema. And the important side effects, if you start someone on sildenafil, you know what to say. It's a dilating agent, headaches, nasal congestion, flushing. The important red flag is visual change. It can cause an ischemic optic neuropathy. So that's the one red flag. They must stop it if that happens. Okay.
Thank you, Dr. Price.
Okay,
It's,
my time.
Excellent lecture, very elaborative and illustrative lecture. Unfortunately, we have problem with the time. Time is not in our favor. I'm sure there may be quite a lot of questions from the audience. However, with the interest of time, let us conclude this session. Thank you very much.
Pleasure to be here.
Thank you very much.
Thank you, madam, for contributing.
I have a special token for appreciation for you, Dr. Laura.